The second speaker is Professor Lei Zhang. 1 year ago, Professor Lei Zhang joined us School of Public Health and as a full-time professor. Professor Zhang is a young scholar, thousands of people apply. He is a director of Chinese Australia Joint Research Center for Infectious Diseases in our school. Professor Zhang published many good papers. He is interested in infectious disease control. He is cross experience with mathematics, epidemiology, and economical health. So we welcome Professor Zhang give our lectures. Please, Professor Zhang.
Distinguished guests, professors, students, thank you very much for this great opportunity to present my studies about this topic, the price of life, the role of health economics in health prevention. So, it works like that. Okay. Okay, cool. Now, so what I'm going to talk about? Well, I'm talking about a number of things. When I talk about disease prevention, actually, I meant HIV infection. So let's narrow down to a single disease for this topic, so make it simpler. Also, when I talk about health economics, I aim to answer two questions. The first, how to spend money wisely, specifically for HIV prevention. Second, how do we best reduce the disease burden of HIV globally? Now, before I move into my presentation, I would like to give a little story. Now, this is a picture of me and my father. So when I was 5, so that little boy over there was 5. So I learned two very important things from my father. One is to think mathematically. So since I was age of 3, so my father started teaching me mathematics. So I don't know why he did that, but it seems to out of some kind of strange parenting strategy. So he decided to teach me mathematics when at the age of 3, which I can hardly read. So by the age of 5, I still remember that I was able to recite the multiplication table at the age of 5. So when at grade 1, when my classmates are still counting their fingers for additions and subtractions, I was able to do multiplication of negative numbers. So I think that's a very important thing that my father had implanted this seed into me to learn mathematics. A second thing I learned from my father is he was a very, very kind man. Okay? So he never lost his temper. He's a role model for me to be kind to others. So these two things made me I am today, so an epidemiologist. So my role as epidemiologist is to use my mathematical skills, and I try to do good for the people around me. Okay, let's get started. Now, let's look at this very beautiful picture. This virus is called HIV. HIV is human immunodeficiency virus. Now, the name itself is very useful. First of all, it's a human. It's not to do with monkeys. It's not to do with pigs. It's not to do with rabbits. It's human. Second is immunodeficiency virus. That means it destroys your immune system and it will cause problems in your body. Okay. Now, so this is a beautified picture. So in the picture, you see a kind of artistic view of the virus, and there are a lot of red blood cells around it. So namely, this HIV virus will stay in your blood if you got infected. Now, if you cut the virus into half, that's what you will see, okay? So there are a lot of parts of the virus, but you don't need to remember. There's only one thing you might want to remember is this circle of receptors, okay? This is called glycoprotein, okay? So the role of glycoprotein is a receptor and also a shield. Okay, I will explain what that means in a minute. Now, HIV is very, very small. Okay, the size of a HIV variant is about 110 nanometers. Nano is 10 to the minus 9 nanometers in diameter. Okay, so the role of GP120, which is over here, okay, so the role of GP120 is for HIV able to connect with CD4 T cells such that it's able to integrate itself into the T cell. Now, what is a T cell? T cell is a sentinel defense cell in your body, which it detects the virus and kills it. So it kills the soldier which is able to define the virus. Okay? So this is a very smart virus. Now, a typical size of T cell is 7 to 8 micrometers in diameter. Okay, so micrometer is 10 to the minus 6. If you calculate the volume, T cell is about the size of 300,000 HIV variants. So imagine yourself is a HIV virus, then a T cell is about the size of the Forbidden City in Beijing. Okay? It's about Forbidden City. Just imagine yourself living in Forbidden City like a king, like an emperor. Okay? So HIV virus is very, very small. But HIV grows very fast. Now, HIV is a DNA virus, right? When I say DNA, that means it can do some reverse engineering, right? Now, if you look at the virus, it can go into the cell, right? Then it reverse its RNA into a DNA, then integrate the DNA into the T cell's DNA, right? Then again, he used the T cell's DNA to reproduce mRNA and make a copy of itself. Then it comes out the T cell again, okay? So one cycle of this integration, it will produce one variant, will produce 250 variants. Just one cycle. Just imagine these 250 variants, they go into T cell again and reproduce again. So second generation, you get 62,500. And the third generation, guess what? You get 60 million. So that's how HIV virus can reproduce very, very quickly inside human body. Besides that, HIV mutates very fast. As I mentioned, so the HIV glycoprotein, the GP120 here, okay, can act also as a shield, right? So it blocks itself, it covers itself, so that your immune system cannot see it. And what's so amazing about GP120, it has variable regions on top of it. And the variable region in name and by its meaning is it keeps changing, right? So every time it copies itself 250 times, it will make a mistake in GP120, such that the immune system cannot recognize the virus. You keep thinking, oh, there's a new virus, because the glycoprotein shielding the virus is keep changing. Okay? So on the bottom here, you see on the left-hand side, when the neutralizing antibody is able to see the virus, it will detect and connect to the virus and waving a flag, hey, this is a virus, this is dangerous, let's kill it. So once the GP120 changes, you can see it changes into purple color. The neutralizing antibodies cannot recognize the virus anymore. Okay? So it can evade the immune system and get away from your body's defense system. So just imagine you have a digital lock, right? You have this PIN number, digital lock. If you change the PIN number every 2 minutes, right, the person would want to open the door, will have to keep guessing the passcode, right? So the HIV virus is like a digital lock that keeps changing the passcode. So that's very, very difficult to find a key to the virus. Now, HIV can hide and kills. So if you go into a human body, now you see two things. The red curve over there is the viral load, the load of the virus, okay? Now, if you see the CD4, the blue curve, this is the CD4 T cells, right? So at the beginning, in the first 8 weeks, you have very sharp viral load. Remember the rapid replication, okay? And it will cause some minor symptoms, for example, like sneezing, some coughing symptoms. But the symptoms will go away after 8 weeks. Then the virus seems to be sleeping. You just go off in your body, it becomes sleeping, it becomes latent. Then there will be a long period, about 6 years. Okay? This is called the asymptomatic phase. But the virus is doing the damage in the body secretly, right? Doing it secretly. So it will reduce your CD4 T cells until we reach a critical level of 200. Once you reach 200, it's called the AIDS phase. So that's a very dangerous phase to be in. So once you reach that phase, a person can easily die of any infectious disease. Maybe a simple influenza can kill a person. So that's how HIV destroys your human immune system and kill you. Now, HIV impacts big. Although it's a tiny virus, it impacts hugely. If you look at the 2017 data, okay, so there were about 36.9 million people are living with HIV then, and about 940,000 people died of HIV. Now, if you change that number into a rate, that means 1 HIV death per 34 seconds. Now, I have been talking to you in the last 11 minutes, okay? So that means about 22 people had already died of HIV in the last 11 minutes. Okay. So also, please note that there is also 1.8 million of children living with HIV. About 110,000 people, just children, they just died of HIV. So these children, they are quite innocent. Now, if you look at the trend lines, on the right-hand side, you can see the number of people living with HIV. It's keep increasing. On the left-hand side, you see two curves. One is the red curve, is that people are newly infected with HIV, and the gray curve is the people who died of HIV. So fortunately, with all the new drugs and new interventions, these two curves managed to decline in recent years. Okay? For example, in 2007, the peak of people dying of HIV is about 2 million. And in 2017, this number get down to 940,000. So it has been half of the people who died, which due to a successful intervention of the HIV epidemic. Okay, if you look at HIV globally, now the red color represents the higher disease burden of HIV. So I'm sure you all agree with me, is that Sahara Africa and South Africa, and most of the Western Africa, they have very heavy burden of HIV, very heavy burden of HIV. And following that is the Americas, the South America, North America, then is the European countries, especially Russia. Okay, this is a complicated timeline curve, right? Now, we know that HIV is not curable. That means you cannot remove this virus if you are infected, right? But this virus is controllable. Now, there's a lot of information on this timeline, but you only need to pay attention to two of them. One is the triple drug antiviral therapy was introduced in 1996. So for this triple drug antiviral therapy is a cocktail therapy that aims to block the virus from integrating and disassembling itself inside the T cell. Okay? And in 2015, WHO had recommends treat all and prophylaxis for people who are at high risk. That means they will use these ART drugs for treatment for everyone who are infected with HIV. Okay? So these are very important landmark times. Okay? So once a person is treated with HIV, the viral load inside their body will reduce such that the risk of passing the virus to the next person will also reduce as well. That's why WHO is pushing everyone to get onto the antiretroviral treatment. Now, it's worthwhile to mention that in the 1990s, okay, the antiretroviral drug, that's how many tablets you need to take per day. Okay, that's how many tablets you need to take per day if you're on the treatment. However, you can see today, we probably just need one tablet, and there's not much side effects. Okay? So it's important to remember one of these drugs, okay, is called the emtricitabine and tenofovir. The short name is FTC and TDF. It's one of the antiretroviral drugs which is using for treatment as well as prevention. Okay? So if you could remember this single drug, it shows you know about HIV. Now, the end game for HIV probably not require a cure, right? Now, of course, on the left-hand side is a person who are infected with HIV, and on the right-hand side is an uninfected individual, okay? So the virus can transmit from an infected individual to an uninfected individual, well, through the following means. It can go through heterosexual transmission, homosexual transmission, which is pretty common in many developed countries. And it can go through multi-to-child transmission and also injection sharing among drug users. There were two ways to stop this. Okay? One is reduce the viral load, as I mentioned, in the infected person, such that it cannot pass on to the next person. Or you just protect the next person, right? Protect the next person by using condoms, for example, among high-risk sexual behavior, such that the virus can be stopped from either side. Okay? So theoretically, if you just wait long enough for a number of generations, maybe 1 or 2 generations, the epidemic will gradually decrease, right? Even though we don't have a cure for HIV. So this is the role of public health. See, public health intervention in a phase that you don't have a good treatment for a disease, for an infection, still you can stop the epidemic. Now, HIV prevention requires strategies. What kind of strategies? Usually, HIV prevention strategy relies on mass interventions. So for one person is enough. It has to be a lot of people, population level, mass intervention. Secondly, usually it's driven by a large program initiated by a government, right? Or a group of government, even though. It will be used as a part of national or regional health policies. So the health policy will have to say, we're going to treat HIV as a priority in our country. And the fourth, it will require collaboration between community, NGOs, and health stakeholders. And more importantly, guess what? They require money, right? So all these things require money. So that's where health economics comes in. Now, in utopia, where it never happens, okay, you have one patient and you have 6 beds, okay? So you always have enough resources for the sick. But in reality, you often have like 6 patients and 2 beds. Okay? Now, if you have so much resources, there's no prioritization. You just go to whatever beds you want to choose, right? But in reality, if you have like 6 patients and 2 beds, you have to prioritize. Okay? Now, for HIV, we have so many interventions. We have so many different strategies, and we have different level of epidemic at different places. Okay? So that's why we need to prioritize HIV intervention in the combat for HIV, against HIV. Now, there are 2 rules for prioritization. Okay, you can make many rules, but these are the main rules. Okay, and also Prof Wang has mentioned some of these in his talk. Okay, the rule number 1, you want to minimize your investment, so you want to spend as less money as possible. Okay, and secondly, you want to maximize your health benefits. So it's a balance of the 2 sides of a balance: the money and the health profits. Now, for health benefits, you can measure that in a number of ways. It can be more life years, people just live longer. It could be better quality of life, right? Remember 20 years back, they used to have like so many drugs with side effects. Nowadays, just 1 tablet a day, okay, and with little side effects. Now, and also with less disability-adjusted life years. So the Pauling and Daly seems to be the other side, two sides of the coin, okay? So the first one is the quality of life. The third one is the disability life. So you want to reduce the disability life. So how to measure cost effectiveness? Now, actually, the indicator is very simple. It's called the incremental cost effectiveness ratio. It's measured by the incremental resource required by the intervention and divided by the incremental health effects gained by the intervention. So it's delta C, delta cost, divided by delta E, okay, which is the intervention. So the formula is very simple. I'm sure anyone who attend primary school will understand this formula. And on the right-hand side, you see a cost effectiveness plane. So the x-axis is the effectiveness, and the y-axis is the cost. Now, if an intervention, okay, it spends money, but with lower effectiveness, right, then obviously we reject that intervention, right? Common sense. Because you spend so much money and you are losing benefits, so you don't want that. On the other hand, okay, if you have a better effectiveness, okay, and you reduce the cost, we always done that. We always want this intervention, so it's called dominant. It's called dominant. However, at some places, we increase the effectiveness and we also increase the cost. In this case, we come up with the concept of willingness to pay. So that means how much a government is willing to pay to invest and gain something health benefits back. So this straight line over there is called a willingness to pay line. Okay? So below the line is so-called cost effective, and above the line is called not cost-effective. Now, worth to mention is the worth to pay threshold, that straight line, in developing countries is usually named as the 3 times GDP per capita. Okay? So for example, the GDP per capita in China is about 8,000 US dollars per year. Okay? So for China, the WTP is about 24,000 US dollars. Okay, health economics in HIV intervention. Now, HIV interventions have become a global issue. Usually, state sponsors funded by the government is required to fund all these interventions. When you consider an intervention, a mass intervention usually means lower unit cost. So when you roll out an intervention, for example, you want to give drug to 10 people, it's always cheaper by unit cost to give the drug to 1,000 people because the manufacturer company can produce drugs more cheaply with more users. And also, we need orchestrated efforts, means more efficient implementations. Yeah? So when the NGOs, the patients, and the governments are work together, then the efforts will be very efficient, very effective. Okay. So the government's funding usually ensures continuity in the health economics in HIV intervention. Now, I want to give you 2 case studies from my research, okay, in the rest 15 minutes. Okay. The first study is a study we conducted in Bangkok, Thailand. Okay. So this study is a scale-up of HIV treatment for MSM in Thailand. So MSM is men who have sex with men, for short. So basically, it's people who have engaged in homosexual sex, and it is a high-risk population for HIV infection. Now, why is HIV treatment so important? Right? If you look at viral load, and this is schematic diagram, so the viral load will increase until a point that you give them treatment. Viral load can be reduced sharply, just in a couple of weeks, right? Sharply to undetectable level. Okay, so this is 10 to the 1, so it's not 0. Remember, it's not 0. It's just to an undetectable level. But however, once you remove the treatment, remove the tablets, then the viral load will bounce back. Okay, right. So that means if a person is on treatment, then it's not infectious, right? It's not contagious. He cannot infect another person, even though he might engage in high-risk sexual behavior. So we try to block this way. Okay? So this is the U equal to U campaign. So U means undetectable viral load, and it equals to untransmissible HIV. Right? So this U equal to U campaign is pushed by the WHO in recent years. Now, back to HIV among MSM in Bangkok. Now, there are around 165,000 of MSM living in Bangkok. Okay, so you know Bangkok is a very colorful place. There's a lot of things happening in Bangkok. So you can have a lot of commercial sex for men, right? For men in this place, in this city. Among these 185,000 MSM, about 1/3 of them, 30% of them, they're high-risk MSM. Okay. However, only about 23% of this high-risk MSM will receive HIV testing. Okay. And among those found to be positive, which are about 28%, okay, only 82% receive ART, right? Eligible for ART. However, only 989 individuals or MSM will initiate ART. So when you look at this cascade, you realize that not many people being tested for HIV and not many people are getting on ART in Bangkok, Thailand. So the aim of this project is try to find the best way, an optimized way to push up the coverage of ART treatment in this very high-risk population. Now, before I go to that, a bit more epidemiology will help, right? Now, look at this line over there. We see an increasing HIV prevalence among MSM in Bangkok in those years. Okay? So even though the treatment is also projected to increase in the coming years, okay? Now, this prevalence is very high. It's somewhere between 20 to 30%. Okay, it's unimaginable. Now, in China, in our country, this HIV prevalence was only observed in small pockets in Sichuan province. Okay, there's some very high-risk MSM in Sichuan province which have a prevalence above 20%. For China, the average, national average, is somewhere between 6% to 8%. So 20% in Bangkok is very high. It's all to do with their extraordinary sexual behavior. Okay, then we look into the location of this MSM. It's very interesting though. So if you look at the map here, this is a map of Thailand, and the little square there, the shaded area, is Bangkok. Okay, and we outlined the Bangkok district, and we found that there's 4 areas where MSM goes to. Okay, so MSM will always come to these places, and you see the dots there inside the shaded area. They are the shopping centers, saunas, parks, and you will see all the MSM that would like to be at these places. Now, the mathematical model for optimization. Basically, I cut down all the formulas, right? Because I think it would be much more difficult if I present some formulas, and this is not a mathematical lesson. Now, first of all, we need to determine an ART coverage. So we need to have a target. For example, we want to achieve 80% coverage of ART. Okay, so this is target we want to achieve. Then we want to calculate how many tests and how many extra ART initiation we need in order to achieve this target. Okay, so always work backward. We have a target. We ask what resources do we need to achieve this target. Then I'm going to ask, we were going to have that X amount of tests and X extra amount of people on ART, then we have to do the following things, 4 things. First of all, we need to link people to HIV testing facilities. Second, we need to physically provide them with the HIV test. And the third is for those diagnosed to be HIV positive, we need to link it to ART. And then we have to provide ART. So each of these steps will cost money, right? So we have CX1, CX2, CY1, and CY2, right? And then I show you the formula, which you don't need to remember. And the whole point is to minimize the sum of this formula. Yeah, so simple, huh? Okay, that's it. So I move to the next figure. So this figure actually presents 3 scenarios, right? 4 color lines. Now, you see a light blue color line is we do not do anything. We just let the epidemic go, and we'll just do business as usual. Well, the ART coverage is still projected to grow because we have more people found to be positive, and we have to treat them anyway, right? Okay. However, we can also scale up the coverage, right? We can invest extra money, we scale up the coverage. In this case, we can achieve 80%, well, we call it 80% universal coverage at the time in 3 years, 5 years, and 10 years. So the red one is to achieve them in 3 years, Okay? At that time, the study was conducted in 2012. So in 3 years was in 2015. So in 5 years in 2017, in 10 years in 2022. Okay? So if we set up different targets, then we have different situations, different results, outcomes. Okay? So on the left-hand side is the number of deaths. On the right-hand side is the number of HIV cases. Well, if you just do business as usual, okay, you will see a very slow but gradually declining trend of HIV deaths and a slow declining trend of HIV infection, new infection. However, if you manage to scale up ART, then you will do much better. Okay? So you can see that for the red line over there, it have a massive drop in HIV deaths and also a massive drop in the HIV infections. So I jump straight into the results table. Okay, so many numbers here, but I only want you to look at the red boxes one. So with these 3 scenarios, these are the amounts, extra amounts we want to invest. Okay, if you want to push up the coverage very quickly, you have to spend more money. So this is about 175 million US dollars to scale up by 2015. But if you want to do it slowly, you spend less money, right? So you only spend 129 million US dollars. And the number of DALI, the disability adjusted life years, okay, is 252.4 per thousand. Yeah, 252,000 DALIs saved, averted. And for this case, it's about 158. But most importantly, if you look at the cost per DALI averted, which is the ISA, is somewhere between 350 and 418. So if you look at the willingness to pay for Thailand, it's about 17,400. Okay? So that means that ISA is well below the willingness to pay ratio, namely that intervention will be highly cost-effective. Okay, let's move into the next more interesting case study. So this case study will be looking into the integrated approach for triple elimination of mother-to-child transmission of HIV, hepatitis B, and syphilis in Cambodia. So this study was conducted in Cambodia. You know that this virus can be transmitted from a pregnant woman to its baby. Okay? So our role is to try to prevent this to happen. Okay, so again, a very interesting timeline is in Cambodia, PMTCT was initiated in Phnom Penh in 2001, and in 2017, WHO adopted a regional framework for the elimination of mother-to-child transmission of HIV, hepatitis B, and syphilis. So between all these years, a lot of things happen, but most importantly is that in 2011, Cambodia actually declared elimination of mother-to-child transmission of congenital syphilis, right? So this is one of the major events. However, our study was conducted under this framework, 2017 framework, to look at what happened, what's the cost-effectiveness of eliminating HIV, hepatitis B, and syphilis in Cambodian pregnant women. Now, over the years, the coverage of HIV screening has increased substantially. And for syphilis testing, it remained about 45%, which is not so good. It's just not so good. And for hepatitis B vaccination, it's doing pretty good. It's 89% in 2015, and about 84% of the newborns actually received the first dose hepatitis B doses. For individual programs, they seems to be all right, except from syphilis. But the whole idea is to combine these programs together. So at the moment, the antenatal care, HIV, hepatitis B, and syphilis, they all operating separately. Our idea is to combine them together, right? We make it into a regional framework by integrating all this prevention into the antenatal care framework. So the aim is to evaluate the cost-effectiveness of integrated approach of the triple immunization in Cambodia. So there are 3 scenarios in this study. Okay, so the current approach is everything was done independently, HIV, syphilis, and we going to simulate a scenario where we have integrated approach for HIV and syphilis. And then in scenario 3, we will have, in addition to scenario 2, we'll have hepatitis B vaccination and have also hepatitis B immunoglobulin solution for the newborns. So the solution is a way to reduce the risk of Hep B intervention, Hep B infection of the newborns. We may also have antiviral drugs for the pregnant women. Okay? If the viral load is very high, then we have the combination of the 2. Okay? So in simple terms, at the moment, it's HIV and syphilis separately. Then in second scenario, we'll combine them together. And the third scenario will have hepatitis B intervention and 3 together, HIV, Hep B, and syphilis together. Okay? In brief, that's what it is. Now, so this is a very complicated schematic flow chart that demonstrates the provision of care and intervention for PMTCT during pregnancy. Okay? During pregnancy. Now, you can ignore pretty much everything on the right-hand side. Now, for the syphilis-infected, HIV-infected, hepatitis B-infected mothers, they will have different ways to deal with them. Okay? So that is the procedure of dealing with them. And during the labor and delivery, we also have various strategy for syphilis-exposed, HIV-exposed, hepatitis B-exposed newborns, babies. And after birth, and we also have the corresponding pediatric care, okay, for HIV-exposed infants, hepatitis B-exposed infants, and syphilis-exposed infants. Now, what I want to show you is not a specific in all these flowcharts. All I want to show you is how complicated this flowchart is. So we have all these complicated decisions to make. Now, what we do is create a decision tree analytic model, right? So I don't expect you to read everything on the left-hand side. This is a mathematical model we created. The idea is to create a decision tree. Now, I'll actually blow up one of the tree to demonstrate what I meant. For example, if someone is diagnosed to be HIV infected, she might choose to continue the pregnancy or discontinue the pregnancy. If she decides to continue, then she may decide to receive ART or not receive ART. Right? If that she receives ART, after the baby is born, she might choose to breastfeeding and not breastfeeding. Okay? And all these will have the corresponding life outcomes. So this is just an example showing that this is a comprehensive decision tree model that simulates the flow chart in real life. So we make the real life into a conceptual model. And I neglect all the statistics and maths behind it. Right, let's go into the results. Now, the integrated model actually shows that when you move from scenario 1, right, the current situation, to scenario 2 by combining HIV and syphilis screening, actually we save 90% of the time of the healthcare workers and 32% of the time of the pregnant women, right? Then it saved about $380,000 in implementing EMTCT. Besides that, if you look at scenario 3, then of course we have an extra hepatitis B intervention, then the hours will be higher, and so is the money. However, when we look into the projected population outcome, the current situation is mother-to-child transmission in Cambodian women. For HIV, it's about 6.6. For hepatitis B, it's about 14.1, and for syphilis, it's 9.4. Right? If we jump straight into scenario 3C, okay, these numbers will be dramatically reduced. Right? For HIV, the reduction is relatively less because HIV is the earliest intervention they have implemented. It's quite mature. But for syphilis and hepatitis B, you can see that will be a large decline if by combining these three interventions together. Now, on the right-hand side, okay, so this is the willingness to pay line, the 3 GDP. This is 1 GDP, and these are the scenarios, okay? Worth to mention is scenario 2 actually have benefits, but it's also save money. So this is in the dominant region, and other scenarios, scenarios 3A, B, C, they're all cost-effective. Okay, so again, so this slide just showing that all these interventions, they have a very low number of cost-effectiveness ratio. It's about 64 to 114 per DALI averted, so which is highly cost-effective. Okay, conclusion. So the end game for HIV requires a generation of ongoing efforts. The treatment as prevention to reduce HIV transmission is highly cost-effective, and the integrated model for elimination of mother-to-child transmission is also cost-effective. So I hope the legacy will go on. Okay, so this is my 5-year-old daughter, and I'm teaching her mathematics, right? And I'm also teaching her to be kind to others. So hopefully one day she will be an epidemiologist, maybe a public health worker. So thank you very much, everyone.
Thank you, Professor Zhang. Professor Zhang tells us a story about his research and interest about infectious disease prevention use, mathematics modeling, and health economics evaluations methods. So, any questions?
Good afternoon, Prof Zhang. Thank you very much for your great presentation. I'm a student in basic medical college, and my major is immunology. But I have a question about if one person was infected by HIV, but doctor didn't found antibody in his body, so can we exclude he suffer from AIDS? Or otherwise, can we say his immune system defeat the HIV?
So you're saying a single person is infected with the virus,
yeah,
but the doctors cannot give a positive diagnosis.
Yes.
And your question was whether we can say this person is somehow being infected with the diseases, or they will be somehow compromising the immune system of the individuals. Okay. So the question is a very interesting one. So if someone is infected with HIV, usually it has to be a positive diagnosis. So if someone is got infected, then the doctor have to say this person is infected, right? If the test is negative, there could be two possibilities. One possibility is the infection is still in the window period. So in the first couple of days of infection, right? So the viral load is still very low, and the test might not be sensitive to pick up the virus. Okay? So probably if it's negative diagnosis, then maybe this person should wait another couple of weeks and do the test again. Okay? So if you do a test again and still negative, then we can believe that the person would be HIV negative, right? And for HIV positive individuals, the deterioration of the immune system takes years. But if you take antiviral drugs, as I mentioned, it will significantly suppress the virus, right? Suppress the virus to a very, very low level. Okay? However, antiretroviral drugs in these days, they're designed to be used for a lifetime. So once you start the drug, you have to keep using it for the rest of your life.
Oh, thank you. Thank you for your information.
Next question.
Okay. Hello, Lao Xie. I have a question about the graph you showed us earlier. It showed that Middle East and Middle Eastern countries have the least prevalence of HIV. Middle Eastern countries having the least prevalence of HIV. In your opinion, why is that?
Most likely it's due to lack of data.
Lack of data?
Yeah.
Okay.
And besides that, so this is a kind of average, regional average figure. So you look at individual countries, you will see the differences. So from the Middle East region, I don't believe that is very low. It's just we don't have the data to tell the prevalence. Because due to culture and religion differences, a lot of these epidemics, they are not uncovered. So they're hidden there, they're transmitting. But the healthcare system is not able to pick them up, I would say.
Well, I think you should consider making a research about that. It's going to be interesting.
Definitely, with you.
Okay. Thank you very much.
You're welcome.
Last question.
Okay, thank you, Professor Zhang, and it was an awesome lecture. I enjoyed it. My question is, as a student from Africa, there's a lot of African countries who have the economy, who have the income, like they have higher income as a government level. And the international organization is such as like all these United Nations are spending a lot of amounts, billions of dollars every year. But still, their healthcare coverage is not doing good. They have the highest mortality. Based on your experience, what do you think? They have the income, they have the money, but the rate and the dying rate, the mortality rate is always high. Thank you very much.
Yeah. I totally agree with you. The transmission of HIV in African countries is mostly heterosexual. That means we have a generalized epidemic, right? For example, in comparison in China, the epidemic is mostly focused in specific groups like gay men and drug users. But in Africa, mostly it's heterosexual, right? So it transmits between husband and wife. So usually the prevention or condom usage is lowest. So it's very easy to transmit. I mean, I was in Uganda. I was in Uganda for 3 months. Okay? I was living in a village, a very rural village, without water, electricity, and toilet. Wow, it was a very exciting experience. And I spent the time with the villagers. They're all very, very nice people. At that time, we were trying to understand the viral load among under 5 children, HIV viral load under 5 children, which is very high. At the time, it's about 5 to 6%, right, which is really, really high. But nowadays, with the prevention of mother-to-child transmission for HIV, and with so many good work all these organizations are doing, I think the rate, so mother-to-child transmission rate can be and is being controlled and it has been reduced by this intervention. But in the long term, of course, I think Africa is the epicenter of HIV, especially Uganda is the epicenter of HIV. And I hope that a lot more resources and smart strategies can be used in this part of the world. Yeah, I'm looking forward to visit that country again in the future. Yeah, thank you.
Okay, thank you, Professor Zhang again. Thank you. Yeah. I think the two professor lectures were very, very good. I think maybe by these lectures, I think maybe many students become interested in public health. And we hope you visit the Professor Wang's Global Health Institute and visit the Professor Zhang's China, Australia joint research center for infectious disease. Thank you very much. Thank you. You attend this afternoon's lectures. Thank you. That's all for today. Okay.